Thank you, Catherine. Thank you to Hepatitis B Echo, Hepatitis B Foundation. Anusha, thanks for helping set all this up and working out the technical sides. This is going to be a Delta Hepatitis 101, but really we'll be doing 202 and 303 sort of nested in here. These slides are available for sharing and broad sharing anywhere you want in PowerPoint format. So you'll get a copy, you can do whatever you want with that. And I'm going to move pretty quickly because you have access to these slides and you could go a deeper dive, send me emails, work out with Catherine, go back to our Delta Connect team at Hepatitis B Foundation also. So this is a nice little starting point. Every person in this world needs to know their ABCs, and in this case, it's A, B, C, D, E. And Delta, of course, is the deadliest of all these viral hepatitis, both from a risk for acute liver failure and also cirrhosis, liver cancer, liver failure, liver transplant, and death. We're going to go into all of these numbers, but it's really nice to start out with this grid. And of course, Delta hepatitis requires hepatitis B, specifically hepatitis B surface antigen for packaging and subsequent infection of other liver cells or other people. There's one small exception to that rule, but I think it's best to stick with that. Delta virus is also a very interesting virus. We'll go into the virology in a moment. It's an incomplete virus and uses host enzymes also for its replication cycle. This is transmitted the same way hepatitis B and C, which is body fluids contaminated with blood components. So anything where you have body fluids with potential contact with blood, you're going to be at risk for transmission. Symptoms in general are nonspecific, like you see with other forms of viral hepatitis, until you're up to the point of being jaundiced or developing liver failure. And there's an acute form and, of course, a chronic form of Delta hepatitis. We're going to go into that as well. And we're going to go into all these risk issues. So this is just a nice summary intro slide. This goes through graphically about how this is transmitted. The main point on this slide is mother to baby transmission is very rare because Delta virus suppresses hepatitis B replication by stealing some of the B machinery for replication, putting the mother at a much lower viral level for hepatitis B, and also the Delta requiring B for transmission is going to be lower risk because hepatitis B transmission is a lower risk. Of course, there's all these risk things you can take into account when thinking about testing for hepatitis B, but now we're testing everybody, right? They're making it simple. We're doing the same thing with Delta, since it's very difficult to take a complete risk history due to time, stigma, patients forget, patients don't want to disclose. So the advocacy position right now, the policy recommendation is to test all adults, all hepatitis B infected individuals for Delta. This applies much more to adults, but Delta infection can infect children as well. Mm. Here's a little bit more on risk factors. It just basically comes back. Let's make this simple. Whenever you make things complicated, things don't happen. That's one of the reasons for hepatitis B, B as in boy, that the number of people being treated globally is under 5% because the guidelines have been so complicated. The new Chinese guidelines for hepatitis B basically are advocating to treat everybody with a few minor tweaks. WHO has simplified theirs down to the point where about 70% of individuals would be on treatment with nukes. And of course, these same guidelines have advocated checking hepatitis B patients for Delta. Again, let's make it simple. Simplicity is the only way we're going to get to elimination. A little bit more on epidemiology. There's a big problem with the lack of data and accurate data. There was a meta-analysis published across 83 countries that estimated Delta was as high as 60 million people in the world. There's so many problems with this paper. I put a line through it saying, ignore this publication, ignore this data, and go back to that 12 to 15 million individuals who are either Delta antibody positive or actually actively infected with Delta. And we're going to get to testing in a moment. One of the problems also in the US has come up recently because we're trying to get therapies approved through the FDA. Gilead went to the FDA for orphan drug designation for bulevirtide and received orphan drug designation in approximately 2017. Bulevirtide still is not approved in the US for some complex reasons, but there's no doubt about the efficacy and also no doubt about the safety of bulevirtide. Bulevirtide is being used in Europe, and I believe right now the number is over 3,000 people with Delta infection in the Europe region are on bulevirtide today. So why am I bringing this up again? So two other companies have gone to the FDA through the Orphan Office of Drug Product Development, ODPD, and both companies were turned down and were told that now Delta prevalence is much higher in the US than 200,000. The number 200,000 is a magic number. Under 200,000, you can get an orphan drug designation. Over 200,000, you don't get orphan drug designation. They responded to these two companies with letters of response and quoted only two publications. These two publications were very interesting, biased. One had a major problem with test inaccuracy, the serologic test that was being performed. And in fact, one of those two papers that the FDA ODPD depended on will undergo a retraction very shortly. So then they'll be down to just one paper that they're using out of about 15 epidemiologic papers to say the prevalence is over 200,000. All the other publications have put the prevalence somewhere between 2 and 5% of hepatitis B infected individuals, which would put Delta in the US somewhere in the 60 to 120,000 range, far below 200,000. So in summary, I'm developing a paper in collaboration with Sherry Cohen, Hepatitis B Foundation, Homi Razavi, and a long list of other people, which I don't have time to name everybody, who will be submitting this letter of request to the ODPD to move Delta to an orphan drug designation for all companies coming into this space to level the playing field and to be accurate. Lots and lots of data here. I'm not going to walk through all this graph, but we do have a lot of information. It's not complete. And usually because we're academics, we'll say it's never complete and it's never fully validated. But we do have enough information to put this estimate in that 2 to 5% range for most countries. There are a few countries with very high prevalence, Mongolia, Pakistan, some of the other stands such as Uzbekistan, Kazakhstan. Some of the Eastern European countries also have a high prevalence. There's an area in South America with a high prevalence, but we're really talking about global. We're talking about the great majority of out of 200 countries that are around, over 190 of those have moderate to low prevalence of Delta. This is a simple slide on genotype. Genotype 1 is by far the most common. North America, Northern Asia, Europe, Eastern Europe, Western Europe, and you find genotype 1 in a number of other places, including India and Australia. But we don't genotype clinically. We do this for research purposes, epidemiologic purposes. And there is some difference in behavior between the genotypes, but I don't have enough time to go into great detail here. I'm just going to say this is a placeholder for further discussions. A little bit more here about prevalence issues. And what I want to highlight here is lack of test availability. Even in the US, until very recently, the largest or one of the largest commercial labs in the United States, LabCorp, did not have Delta testing available in-house. If you ordered it through them, they had to send it somewhere else, and that led to all sorts of problems with access and insurance or reimbursement. But now the four major labs, Mayo, ARIP, Quest, and LabCorp, all have Delta antibody testing available. And your first test for screening is an antibody. Then if antibody is positive, you move to PCR RNA quantification. Never use a qualitative PCR test. Never order IgM for Delta, and never order Delta antigen. It's very simple. Total antibody, that's positive. You go to quantitative PCR. Quantitative PCR positive, you've confirmed active infection. So here we have all these unmet needs. We have this large number of people infected, and the number of people screened for Delta inside is actually runs between 10 and 25%. So the second bar here is a little bit of an exaggeration. Diagnosed is another problem because you don't diagnose Delta until you have both antibody and PCR, because it's the PCR that documents active infection. And then management, people under respect Delta. They're not sure what to do. They say there's no treatment, so I'm not going to change my behavior. Of course, that's wrong. If people are Delta actively infected, they need to be managed and seen more frequently. They're much higher risk of earlier HCC, earlier cirrhosis, earlier liver failure, maybe going to transplant. So every patient with Delta hepatitis needs to be managed more aggressively, more frequently than a hepatitis B patient in general. Let's talk about virology. This is a very, very interesting virus. Again, it's an incomplete RNA virus that moves in the body underneath the coverage of hepatitis B surface antigen. So it requires surface antigen for packaging, excretion, circulation, and then back to infecting other hepatocytes. There is some data that when cells divide, Delta can move with cell division without going through this replication cycle. But I'm going to say this is 98% of the story that's on here. The hepatitis B and also carrying Delta is taken up into the liver cell with this bile acid transporter called the NTCP. The RNA gets uncoated, goes into the cytoplasm, goes into the nucleus, replicates, undergoes something called prenylation. That's a host enzyme that's required for packaging and then release. And when you have Delta, it suppresses hepatitis B replication. And I'll show that graphically in just a moment. This just gives you a little bit larger diagram on how this circular RNA is modified and then sits inside the hepatitis B surface antigen as an envelope coating, and a little bit more on the right side about how this entry takes place. A little bit more of a summary here. It's a very interesting virus moving between a genome and an antigenome. It has a large and a small delta antigen. These delta antigens interact back with the delta virus, can actually suppress delta replication if one of the antigens is too far in excess. Let's go back to natural history and disease progression. In most patients, the left graph is what you see as dominant, which is called the viral load graph, where you have a high level of delta RNA and a low level of hepatitis B DNA. This has to do with delta competing for replication mechanisms and suppressing hepatitis B through this competitive process. Occasionally, maybe about 10% of patients, delta and B is low to moderate levels. And in very rare cases, delta RNA is low, detectable, and hepatitis B replication is high. And this might even take place after someone's been treated with one of the medications, such as bulevirtide or the Replicor compound, or some of the other experimental treatments where you reset the delta RNA replication to a low level. That's good news because the lower the virus, the better the prognosis. Now let's talk about how Delta infects individuals. So we have something called simultaneous. They use the word co-infection, which is a little confusing, but we'll call it simultaneous. If you get B and Delta at the same time, there's good news. Often B and Delta are both cleared. I'm not going to use the word cured, but cleared from the blood. Chronic infection is basically 1 out of 5, but also a high risk of progression. Then you have superinfection. Someone's carrying B, has some type of risk event, then gets Delta, and that's called a superinfection. 1 out of 3 spontaneously clear Delta and may clear B and Delta. 2/3 have chronic infection, and it's these chronic infection patients who really have this accelerated course to cirrhosis, liver cancer, transplant, liver failure, and death. D is for deadly. We basically give the term 70% lifetime risk of a fatal outcome if you're Delta infected with hepatitis B. Now, over time, it's interesting. This is over 20 or 30 years. Delta RNA levels sometimes undergo their own reset. You may see the same thing with hepatitis B. Both the replication levels may lower over time. This is going to be good news because less virus means better prognosis, but many of these patients have died during this chronic phase, this high replication phase. This just talks about risk, cirrhosis, liver cancer, decomp, liver transplant, and mortality, comparing Delta plus B in the pink and red compared to B alone in the blue color. The multiplier is very substantial. That's why we say D is for deadly. A little bit more on numbers in terms of decompensation, this liver cancer risk, and mortality. Faster progression. You may get liver cancer at a much earlier time point. As you know, with hepatitis B, the liver cancer risk really starts going up after 30, 40, 50 years of infection. Although we know children can get liver cancer from hepatitis B as well. And we saw some amazing changes in hepatitis B associated liver cancer in children with modeling that took place in Taiwan, who was really the first country to implement broad-based infant vaccination, neonatal vaccination. But because of the aggressive course of this disease to cirrhosis, that increases the risk for cancer. But separate from the cirrhosis risk, Delta increases the risk for liver cancer. That's why I'm saying, even if we don't have a direct treatment available, or we don't like using interferon for Delta infection, these patients need to be managed more closely. Testing for Delta makes a difference if you as a provider engage in the seriousness of this disease. This walks through virus persistent, chronic hepatitis, time to cirrhosis, time to cancer. There is a subgroup of patients, though, with Delta, and it's probably 15%, who have very mild disease who don't progress. We don't know why. It may be some genetics, just like we know genetics with fatty liver makes a difference. Genetics with alcohol makes a difference. There may be some genetics with the virus, the immune system, the response, such as fibrosis, other issues that are involved. So there is a small subset who don't progress. There's another subset, 15%, that are very slow progressors, and it takes us back to that 70% who are high risk for progression in a shorter period of time, less than 20 years. What else? Delta results in a decreased quality of life, more abdominal pain, increasing anxiety, stigma, societal stigma, self-stigma. This does appear to relate to the level of virus. So more virus means more inflammation means more symptoms, more cognitive issues, and even more virus may come back to the patient feeling like they're more infectious, because they are. The higher the viral level, just like with B, the higher the viral level with Delta, the higher the infectivity. So this is a quality of life issue. This is really now about the patient, not just about what we call hard endpoints, but these are patient endpoints. Lack of information, lack of awareness, lack of access to providers. It says doctors on here, but providers is the better word. This includes pharmacists, nurse practitioners, physician assistants, advanced RNs, MDs, DOs. There's a whole army of us out there that need to be educated and need to be able to inform patients correctly. And of course, we need access to medications. I'm really trying to get the FDA to recognize this as an orphan disease. And this allows more companies to come into the space. Gilead's clearly at the cutting edge, but there's 5 other companies that I'm working with as a consultant who are interested in developing drugs for Delta. This should be an orphan disease that gives the companies some financial advantages and incentive to develop a drug that's for a rare condition where their return on investment may not be as good or as big to justify the research that's involved. You all can help with spreading this information. starting to do sufficient testing and bringing testing to all of our hepatitis B patients. We're trying to bring this testing algorithm availability throughout the world. We're working very closely with Hepatitis B Foundation. My activities of touring the world. I'm on the road 7 to 10 days a month outside the United States, working on hepatitis B and Delta advocacy activities. We're trying to get more accurate tests. I think it's public knowledge that diazorin is working their way through the FDA with an antibody test that I think will meet the stringent guidelines by the FDA for sensitivity and specificity. There's a number of companies, including Roche. Again, this is in the public domain. They're working on PCR quantitative assays that are regulatory approved also. Let's keep information up to date and get rid of outdated misinformation. Patients with hepatitis C and B, HIV, B, and Delta, this tri-infection or quad infection, have an even a higher risk of disease progression to cirrhosis, cancer, liver failure, death, and transplant. So everybody with B, of course, should have hepatitis Delta. Everybody with B should have HIV. Everybody with B should have hepatitis C information in their chart. Then, of course, you're going to start doing liver cancer surveillance as soon as you document advanced fibrosis. Or if you happen to do testing like I do, in my patients, I get a baseline liver cancer triple panel, and I use that triple panel in something called a GALAD score to determine when I'm going to start liver cancer surveillance in non-cirrhotic patients. This just talks about outcome with Delta infection when you have a tri-infection, B, HIV, and Delta infection. And this is a lot of complicated information on this graph, but documenting worse outcomes. A little bit more on this issue. When you have a decreased Delta RNA, you have better outcomes. The lower the RNA level, the slower the progression. You may halt progression, you may even reverse progression. And when you lose Delta RNA, treatment-related or not treatment-related, long-term complications are substantially less. We also saw this with some very old interferon data, that when you do a reset, if you can take that viral load down 2 logs or more without clearing Delta, you have better outcomes, better long-term survival. Now we're using that as an intro to treatment. I want to emphasize on this slide first, before I go into the interferon world, that entecavir, lamivudine, which we don't use anymore, tenofovir, TDF, tenofovir, TAF, none of these nukes affect Delta replication, but they all suppress hepatitis B replication. And in a Delta B infected patient, you want B to be fully suppressed. So my advocacy is to put everybody with Delta on a nuke, making sure hepatitis B DNA is undetectable. Now, interferon has been published in a variety of different papers. You can look at the 4 top, and then there's 3 at the bottom with combination therapy. And you can get Delta RNA clearance in a number of patients at the end of treatment. It could be as high as 70% in this one small study. But long-term, this virus relapses when you stop the interferon. So long-term viral suppression post-interferon treatment for 1 or 2 years is 15 to 20%. That's RNA undetectable. I'm not going to use the word cure. I'll use the word maintain viral suppression, maintain viral response. And those patients do better. So I discuss interferon with all of my Delta patients, but most patients live in great fear because of the history of interferon and side effects. It just has a bad reputation in the US population. But if you move to Asia, specifically to China, half the hepatitis B patients in China have seen interferon, in my opinion, at least been treated short term with interferon therapy with good tolerance. And in the hepatitis B world, interferon is part of at least 5 major drug development programs that are in phase 2 or phase 3. The pegylated interferon is around. It's not ideal. It has side effects. And now we have bulevirtide, globally, hopefully. We definitely have it in Europe, and we're hoping to have it in the US soon. And we're going to talk about bulevirtide now as an entry inhibitor. It blocks that NTCP receptor and stops that liver cell from getting a new infection or getting reinfection. You can get a nice biochemical response with this ALT normalization in up to 60% of patients, and a virologic response, meaning the virus is down 2 logs or negative. And that is good news because that changes outcomes. But bulevirtide is a chronic treatment, it's a daily injection treatment. And that is a catch. Most of our patients want finite treatment, and I'll get back to that in a moment. Lonafarnib research has been halted. Eiger was a company that was developing lonafarnib. It's a complicated story about why that treatment or development was halted. I believe lonafarnib, just like PEG lambda, would have a role in treating Delta infection, but there are some very complicated issues with the drug development, and those two drug development are currently halted. They may come back alive with a second life or a third life soon, but we'll see. Rep 2139 from Replicor inhibits assembly of the delta plus B or B plus B. And there's been some very good virologic responses, including some patients losing S antigen, but I don't know what's going to happen with Rep. There's not a clear pathway for FDA or regulatory approval. Here's a picture of what bulevirtide. It's a pre-S1 mimetic, which is the surface antigen, one of the different types of proteins involved in the surface antigen, and it stops the binding. It says disrupts binding to that bile acid transporter. Some very fancy diagrams here, amazing research from our German team that helped develop this. It used to be called Mercludex, but they changed the name. Mercludex is still used in Russia and in some other places in the world, but it's the same drug, and we're hoping to have this in the US in the next year. This is virologic response on bulevirtide. It's the 2 mg dose. You can see the multi-log reduction. Most of these patients started around 5 logs, and you can see a reduction on average down to about 2 logs. So that's a 3+ log reduction. A number of patients actually cleared Delta during short-term treatment, 15 to 20%, with higher numbers clearing Delta long-term. So the longer you treat with bulevirtide, the more that patients respond. I'm not showing data when you use pegylated interferon in combination with bulevirtide. It's a finite treatment course, and you can get viral clearance rates above 40% using finite treatment. But again, a little complicated because you're giving PEG interferon and bulevirtide for up to 96 weeks. Although that will be my choice once I have access to bulevirtide. My choice would be use interferon plus bulevirtide first. If they fail combo, put them on bulevirtide maintenance. And I think we're almost done, Catherine. Let me just see if I can get control here. So regardless of risk factors, background characteristics, all surface antigen patients need to be checked for delta total antibody. Delta total antibody positive, check RNA quantification. Prevalence estimates are inaccurate, but we believe this is a rare disease, globally less than 15 million, in the US under 150,000. I think it's even lower than that. Hepatitis Delta requires surface antigen. So if we have a new cure for B and we can get rid of surface antigen, we may be able to clear or even cure Delta. And I think Delta cure is possible because I showed you in that earlier graph that 30% of patients without treatment clear Delta on their own when you have super infection, and an even higher number if you have co-infection or simultaneous. Those patients never relapse. The Delta never comes back, even if they're immune suppressed, even if they get a transplant. So I think cure for Delta is on the horizon. It's a realistic expectation. If you have a Delta patient, follow them closely, follow the literature, adjust your management, adjust your monitoring, your surveillance for these patients with more aggressive disease. Down at the bottom, I put in red highlight that every Delta patient needs to be on a nuke. All hepatitis B DNA needs to be undetectable. I believe that slows disease. I believe that's evidence-based. And hopefully we'll have bulevirtide next year in the United States for our Delta patients. I have a patient right now, I just called before I got on this call to find out where his bulevirtide early access is. I had to go through tons of paperwork and consents and FDA interacting with the Gilead team to get access to bulevirtide, but it is available through compassionate use. Just be prepared for the paperwork and compliance and the consent process that's required. Thanks for having me, Catherine. I think we're on a good time course. Hopefully I didn't go too fast, but people have questions, email me. Thank you.
Yeah, thank you so much, Dr. Gish. So just to summarize, it sounds like first, anybody with hepatitis B should be tested for Delta, and those with Delta should also be on treatment to get hepatitis B under control. As key takeaways, certainly. We did have a couple of questions come through the chat. Also, if others have questions, please either raise your hand or put them in the chat as well. But one of the questions was about coverage, and this is specifically in the US and health insurance coverage for Delta testing. I think there's been issues with that historically. Is that still an issue? And are there ways around it that you could advise?
It should not happen. And as you know, the insurance company's job is to block access to care. That's what they do every day with all sorts of pre-authorization and all these other, what I consider garbage in our healthcare system. There should not be a problem. I never have a problem, but the insurance companies are afraid of me because I will fight them on everything, as you can imagine. So if you do have a problem getting coverage, what I would propose is we could get a letter of appeal that we could publish on the Hep B Foundation website or Delta Connect website that you could use to fight this. And I really recommend you fight it out because the insurance companies love to wear us down, make us tired. Oh, they refuse to pay. It won't happen. You won't order it again. It's all part of the intimidation pathway of our insurance dysfunction. So let's fight it out together. Tell us where you need help.
Yeah, definitely. I would echo what Dr. Gish said. Reach out to us if you have any issues. And Dr. Gish, do you have a letter of appeal example maybe that we could use as a template and we can modify and post on our website and also share with this group?
I'm going to make one.
Oh, awesome. Thank you. Appreciate that. And we'll be sure to share that with everyone as well. So in case you do run into that issue, you'll have resources to address. We do have some folks joining us from low and middle income countries. What about access to testing? Any strategies or thoughts on overcoming some of those challenges that might emerge related to Delta access to testing?
Yeah, it's a really important question because if you're a big diagnostic companies, you only going to go into the big markets where you're going to get a return on investment. And one of the reasons we don't have tests that are FDA cleared is the FDA has a very high quality bar. That high quality bar means it's very expensive and there's not a good return on investment for these tests. So there is no FDA cleared test for Delta. And we need not just that, but we need a rapid test also. But as I mentioned, Diasorin is moving through the FDA right now. Roche is moving through the FDA and also having dialogue with the EMEA. And we really, once you get these big markets covered, we're going to advocate for those companies to take this globally, try to get it available in every country. Finally, there's a rapid test that has been published by our German colleagues, and that rapid test has gone silent. And then there was another rapid test that I saw that they did some research on in Cambodia that I think was at the APASL meeting. I'm not sure exactly where it was. I've lost track. So rapid tests for Delta antibody would be super helpful. Then, of course, a rapid test for PCR. If we can get the Affymetrix team, to get a cartridge for that, that would be quite useful. So we're going to push globally to get Delta testing available everywhere.
Great, thank you. And I know that's a priority with WHO as well, as they've recommended in the new updated guidelines for anybody surface antigen positive testing for Delta as well. So hopefully with that will come more resources to support these types of testings. There was a really interesting question. Someone from Mauritania is on the line, and he mentioned prevalence being over 19% for Delta. in this context, do you think that hepatitis B genotypes D and E, which circulate in Mauritania, could be more favorable targets for hepatitis delta co-infection?
It's a great question. A super virologic question. Hopefully everybody knows Mauritania is in Northwest Africa, called the Northwest corner. But I think it more has to do with behavior. This is injection, scarification. There's also other issues that take place, manipulation of different parts of our body that are done in an unclean environment. So I think it's human behavior that drives Delta mostly. But that's an interesting question. For instance, in South America, in the Orinoco and Upper Amazonia, there's a lot of Delta genotype 3. Where did that come from? It's a very different genotype. It has different behavior. It's has a very special name. I think it's called La Brea fever. And it can either result in acute severe jaundice or early clearance. Very interesting virologic, but I think the infection with Delta is a human behavior driven event.
Thank you. That's helpful. Another question. I heard within this presentation that there are two other labs aside from LabCorp and Quest used for Delta testing. Are there testing codes available for the other two? And what are those other two labs, if you don't mind sharing?
So ARUP, ARUP was the first Delta lab in the US. That was over 12 years ago. I think they're available in 2012 or 2013. They really led the charge. You can go onto their website and they'll show you their test codes. Mayo Clinic also was, I would say, in third place. Quest got Delta testing available, antibody and PCR in 2015. Just go onto the websites. You should be able to find it easily. If not, reach out to Catherine and I through our Delta Connect. We will get you the codes.
And I see Brad Collins just put them in the chat as well. So we have the test codes in the chat for ARIP and Mayo, and the code is the same as listed there. So hopefully
Thanks,
that's
Brad.
helpful.
Brad,
Thank you,
thanks for
guys.
listening.
Awesome.
Brad's my collaborator.
Awesome. Any other questions from the group? I just had one other question specific to LMICs and management of Delta. I know you mentioned treatment, getting on hepatitis B treatment is a priority. Any other suggestions for just day-to-day management, particularly in resource-limited settings?
Well, of course, if you identify your patient with B and Delta, you now need to check everybody who's a contact, household contact with them, sexual contact, any intimate contact. And if you have the resources, you're going to start doing liver cancer surveillance and cirrhosis surveillance early. You want to, of course, make sure they're not drinking alcohol. You want to manage metabolic syndrome. If they've got fatty liver, you want to get that fatty liver under control with different interventions, better diabetes management, weight loss. I think all those are important. Delta, fortunately, rarely causes extrahepatic disease, like hurt the kidneys, like hepatitis B or other systems. So it's really heavily focused in the liver, but this symptomatic quality of life issues is very important. And if you have access to interferon in resource limited countries, interferon prices in some countries are very, very cheap. Consider interferon therapy to try to at least reset the viral level and help 20 to 30% of patients.
Thank you. Another question from Dr. Haley Michael, who's done a lot of great research in Ethiopia and has helped kind of assess the treatment landscape and treatment criteria. So it's really great to have him on. He was asking if we gain access to begin screening, could this potentially be a cause of presumed occult HBV infections in patients with advanced cirrhosis or HCC?
So I think I understand that question. So occult hepatitis B is this setting where surface antigen is negative, core antibody positive, and they have B replication. They have measurable hepatitis B. There have been cases where people were surface antigen negative and still had delta replication. You go, well, how can that be? Well, remember our hepatitis B surface antigen test, when it's negative, just means it's below 0.05 international units. doesn't mean it's truly undetectable. It's just undetectable by that test. So patients with B are still making surface antigen, maybe below our test detectability, and you may have RNA delta that could still survive. But this is going to be a rare event inside of a rare event, but definitely a consideration. Hopefully, I answered that question, Dr. Haley Michael, well, and I will look forward to seeing you in Cairo in a few weeks.
Yeah, same. Awesome. Any other questions? These are really great, guys. Thanks for the feedback and the discussion so far. All right. Thanks, Dr. Gish, for your help, and hopefully you'll be able to stay on the line for a little bit longer as